All right, I think we're ready to get started. I think even though the title says goal setting, some of Dr. Thornberry's students came up and thought it'd be better. This would be a time for me just to tell stories from his training days. So I thought I have an hour and a half. That's almost enough time for me to go through my top three Dr. Thornberry stories.
Nobody wants to hear that.
Okay, all right. Well, all right. Goal setting it is. Let me just kind of go. So again, for our learning objectives, to understand how to transition from MI techniques to goal setting for addressing pediatric obesity, a lot of foreshadowing today as far as letting you know that I think MI is how you start the conversation, but you have to have the second piece. You've got to be able to set good goals and set kind of really good expectations. And again, I think the nice thing about our talks today, they kind of build. So we're going to talk some more about SMART goals, which I know Dr. Whedon just kind of briefly kind of went over, about how to use SMART goals for pediatric obesity. Then at the end, we're also going to talk about the role of several kind of concepts that I think are things that you always need to kind of keep in the back of your mind. And some of these are having a shared agenda, developing a menu of options, incremental versus the gold standard. We're going to spend a lot of time talking about that because I think that is a huge issue that we have, is what's the difference between the gold standard. So when I think of 5210, that's a gold standard. I think sometimes that can be overwhelming when everyone sees that. And, if you've got a family, you've got a kid that drinks, 5 Dr. Peppers a day, and that's the way his family's done that, and they go, I'm supposed to drink 0? I think, most of us, I think, that are interested in this realize that it's got to be an incremental approach, that you got to slowly make changes. But I think sometimes it's so important, we have to be very explicit about that. So we're going to spend quite a bit of time talking about it's okay to educate about the gold standard, but what are we going to do tomorrow? What are going to be the steps we're going to move along the way? Goodness of fit, we're going to talk quite a bit about that. Again, I think a lot of times you'll get parents that'll nod their head and they'll be, once they realize, hey, my kids, the labs are messed up, they want to do everything. They want to change everything. Realistically, you can already start to think, okay, the goal they're coming up with, that's not going to fly. Mom's talking about making all these changes, and she just told me that in the afternoon, the kid stays with the grandparents. They stay with the grandparents on the weekend. How's mom even going to implement this? So I think goodness of fit, doing some problem solving, you got to think about that. Then we're going to also talk about choice, because I think choice is key when you're dealing with families. We're going to talk a little bit about parents kind of set the stage, but you have to find some ways to give kids choices. So hopefully the next hour and 15 minutes, it won't be as interesting as Dr. Thornberry's stories, but hopefully we'll keep you awake. So again, I want to briefly review some MI concepts. Again, it's only been, 2 hours, but we're going to review anyway. Again, talk about the relationship, review the goal-setting concepts, and then we're going to talk a little bit about some of the tools and guides for MI and goal setting. And now the nice thing is, you guys are so well prepared. In your packets, you've got information about kind of a little MI script. You also have the Healthy Habits questionnaire, and I think hopefully we'll talk a little bit about how all that kind of comes together for your clinic visit. Again, so just to kind of have a quick kind of review about MI, hopefully, you haven't forgotten the 5 fundamental principles: collaboration, being evocative, autonomy supportive. And again, collaboration, when we think about goal setting, we got to really come together with these families and patients, meet them where they're at. And again, you can be directive, being empathetic. And again, remember what I said before about to do good MI, you have to be genuinely interested in your patients and families. And so part of that by being evocative means evoking from them, what are their ideas about change? Okay, if we identify an area, physical activity, making some dietary changes, before we start to give some suggestions, we should ask them, what do you have? What do you have some ideas about change? And I'll give you an example of this. One of our colleagues, great guy, works in primary care, and he had an opportunity. He had this clinical encounter. He was with, I forget how old the pediatric patient was, probably maybe 11 or 12. Grandma brought the kid in and did their regular well child check, and at the end, BMI was elevated, so he started having a discussion about some changes. And one of the things that Grandma had indicated was again, you guys are in Kentucky, we're in Oklahoma, we all like sweet tea. One of the things that had come up was this kid drinks lots and lots of sweet tea. And again, you've heard this before, that kind of those sugary beverages, that's kind of the low-hanging fruit, right? We know that if you're drinking lots of that, that's a great place to start to make some changes. So this pediatrician and I were having lunch, and he's telling me about this clinical encounter, and he talked about that at one point Grandma said, I guess I could switch, and we could try that Splenda, we could try substituting something else. And I was sitting there thinking, from an incremental standpoint, I thought, that is awesome. I mean, Grandma came up with that on her own. And he said, but I kept asking her, well, if you're going to make a change, why don't you just go ahead and switch just to water? And in my head, I thought, what a missed opportunity. Because here, Grandma had the insight. Grandma was coming up. Grandma was actively problem solving as far as kind of evoking and collaborating. Grandma was saying, I get it. The sweet tea's bad. I could make that change. And he was, and again, his thought was, but the gold standard is water. Wouldn't water be better? Sure, it'd be better. But if Grandma's willing to make that change, I would have done a dance right there. Okay. So again, part of it is we've got to be collaborative. We got to evoke that. If people come up with good ideas, we got to find ways to praise. So I always think about it, that example, because I think when we can do these talks, it can be kind of dry, it can be very academic. I think we can always, the more we can relate it to clinical situations, and that's a great clinical situation where if you've got a parent that generates an idea, you got to jump on that. Figure out a way to make that work. So a missed opportunity. Again, we talked about some of the things. Again, hopefully what you'll see is that the MI strategies will build. And if you look in your packet, when they have the kind of the MI script, all those MI strategies build to having that last little phrase there about, so where do you think we go from here? Once you use the scaled questions, once you ask some open-ended questions, you reflect back, you get that motivation built, you get that some desire to make a change, and you say, so where do you think we go from here? That's where we're going to have to transition into, okay, we got to set some goals, right? Again, this is just review. Because again, remember, advise and educate, you can do that, but you got to do it with permission. And remember, our overall goal is we want to collaborate on those potential solutions and plans. So this is all just review. All right, so I think you have something similar like this in your packet that kind of tells you kind of the little MI script, kind of walks you through it. And again, at the end, it kind of gets to, where are we going to go from here? How are we going to set goals? Again, just a slide to remind you that these brief interventions, the MI and the behavioral interventions, can have an effect. We've talked about the evidence for that. So let's talk a little bit about goal setting. And so again, hopefully what you'll see is the relationship between MI and goal setting is complementary. Like I said before, you open with MI and you close with goal setting. So again, I think of things kind of simplistically sometimes. But remember, MI principles apply to goal setting. So let's first talk about kind of before you get there, one of the things that you should be, as you do your MI, one of the things that you should be doing is being collaborative. You should be thinking about developing that shared agenda, okay? Getting on the same page. And then also be thinking about part of that being collaborative and having that shared agenda as a menu of options. You want to collaborate with, okay, what are their ideas? What are our ideas? How are we going to negotiate this? So let's talk a little bit about how can you assure a shared agenda and the ability to provide a menu of options. So what are some specific things you can do? So again, if we think about getting that shared agenda, if we think about specific MI skills, so we think about those reflections, we think about being explicit about kind of autonomy supportive, so asking permission. By asking permission, they're giving you permission. Everything that you share with them afterwards, they've asked for. So those specific things help align you so you can ensure that you're on the same page. But let's talk about some specific examples. So in your packet, you've got the Healthy Habits Questionnaire. So if you think from a primary care standpoint or any kind of clinical situation, okay, if when the patient and family first come in, if they fill this out, so let's say it's primary care, it's a well-child check, whatever the case might be, they fill this out. The process of filling this out, you're already starting to work on a shared agenda. You're already starting to get them on the same page because you're putting this on on their radar, right? You're asking them, they're filling out questions. We just kind of look through here. Again, Dr. Weed went over some of this, but you're asking about fruit and vegetable consumption. You're asking about, are they eating at the dinner table? By even asking those questions up, you're putting it on their radar, okay? They're starting to think about that. It's making your job much easier because this way, at the end of the session, when you say, hey, is it okay if we spend a few seconds talking about physical activity, dietary changes, and your kid's health? They've already been thinking about it. They've already had some time to kind of sit with it. I got to throw this in for my mom. Does that make sense? She'd love it if I said that. And I think this is a great tool. I think it's probably underused. We do lots of presentations and we talk about that. I heard some people in the audience already use this. That is awesome. Because also what this does is this sets the stage. It changes the culture to where it's okay to talk about physical activity and dietary things at each and every visit. Because part of it is, if the only time we talk about obesity is when it's off the scale, then we set that stigma, right? Because part of what we have to do is we have to normalize that it's okay to have those discussions. We should have those discussions, and that's what some of the guidelines say about BMI. We should be talking with people, if their BMI is in range, we should talk with them, why do you think you're doing so well, right? A lot of times our health system, we get really focused when there are problems. When people are doing good, we pay no attention, okay? So this is something that you should think about, again, if they're doing all these things well, if they're eating at the table, if they're getting lots of fruits and vegetables, things like that, parents need to know that they're doing a good job. So this helps kind of normalize having those conversations, okay? The other thing it does is at the very end, it also says, based on your answers, is there one thing? So that right there, that's also going to join, you're going to get that shared agenda. You already have them thinking, okay, out of all these things, I might want to make a change on one of these. You're setting the table to have that conversation at the end. The other thing is that a lot of times if you ask somebody, do you have any concerns about any kind of dietary things? And they'll say, no. But it's something like this where you have to individually go through and say, oh gosh, they may realize, man, Johnny's watching a lot of TV. Or come to think of it, we eat out an awful lot. So this also kind of raises, because sometimes we get lost in global questions. A good example, again, I'm a clinical psychologist. If you ask somebody, have you been experiencing any kind of depressive symptoms? Or do you think you have any depression? No. And then you give them a detail where to ask symptom by symptom, you'll be amazed, right? Because it's also kind of like, well, I've done this for so long, I didn't realize some of these things were kind of out of bounds on these different questions. So this is a great tool to use to get you to start on that shared agenda. Questions about using this? Because I think the other thing is we have to talk about this. This makes a lot of sense to a lot of people, but it's got to be realistic. Okay, so one of the things is, I think if you build this in, you take away from that stigma. It's a nice way to always kind of briefly have a conversation about physical activity, dietary changes for anybody. But the most important question for you guys is this realistic? Is this something that I think I could use, or a modified version that I could use in my practice? Don't everyone raise your hand at once. Everyone looks so excited. Because I think one of the things we have to do, those of us that go out and preach about, we got to intervene, we have to give you tools to make it simpler to where you can do things on a regular basis.
Can I speak up for a second?
Please
I've
do.
got a huge mouth. I'm sorry.
No, you're good.
We've been using this for years in our practice. We've gone through a couple of different iterations. Partners who I thought would never want to do it now can't live without it because it helps them talk about, just like you said, Steve, it normalizes it. You're talking about 5210, which is good if you're underweight or overweight or normal weight or whatever. And we actually sign it and hand it back to them at the end, so it's their prescription for health also.
Yeah. Well, and I will tell you, so this is just kind of a little anecdote about.
Parents love it too.
So Dr. Weed and I, we're in the same multidisciplinary weight management clinic, and we'll have an afternoon and we'll have 7 or 8 patients that are seeing 3 or 4 providers, and so it's a busy clinic. And it's interesting because sometimes we want people come in and kind of shadow us, and they'll have questions for me like, you spent just as long or longer with that one patient or family, and they're doing really well. Why did you spend 30 minutes with that family? Because it seems like they're doing everything right. And my discussion is, well, because we want to ensure that they're continuing to do everything right. Because a lot of times families will say, well, all of a sudden it seems like, Johnny said his clothes fit better and, our labs are better. So I want to have a conversation about, so tell us what you've been doing. What have you been doing differently? And how easy was that for you, or how difficult it was for you? We need to have those conversations. So I think that, again, I think this is a nice thing you can use whether kids are doing great or kids are really struggling. We need to spend almost as much time, I think, on both sides of the coin.
Our parents have gotten used to it, where like because it's like the opportunity for us to say to them, eat your vegetables, too.
Right. And again, I think one of the things that we talked about, not just from a advocacy standpoint, having consistent messaging. I think things like this help us clinically, even as providers. Sometimes we look and they think back, and sometimes patients and families will say, I've seen you 3 different times and it sounds like your message is a little bit different. Even things like this help us kind of stay on track and be consistent in that message. Any other comments about this? All right. So let's think about, again, I'm going to kind of borrow a slide, but we talked about kind of targeted goals for dietary intake, eating behaviors, sedentary, physical activity. So again, when we think about this dietary intake, limit sugary beverages, 5 servings of fruits and vegetables, eat breakfast daily, all these things. These are gold standards, right? So you got to think about, so if you're setting goals and someone comes in and says, I don't eat breakfast at all. Johnny skips breakfast every day. So part of your job is to figure out, okay, what's going to be a realistic goal? What's Johnny interested in doing? Let's say Johnny's, 12 years old. In your decision making with or your negotiation with them, you got to figure out, what's Johnny willing to try? What can Johnny's parents help support, right? Because we know getting Johnny to eat breakfast, it's not just Johnny, right? It's about his parents as well. So one of the things you have to think about these targeted goals is also kind of figuring out, again, we have to work our way back from the gold standard to what's going to be something we can try this next week. And I think for all these, the other thing, and again, these are all great gold standards to have, but I always have to kind of put in a little side notes on some of these things. And Dr. Whedon started to mention this about sedentary behaviors. One of the things that worries me sometimes is, again, our 60 minutes of vigorous physical activity. We see so many kids that is so far from what they could do. She just mentioned kind of one of the extreme examples where this kid, his BMI is 96, right? And his goal right now is get to where he could walk for 7 minutes. To walk for 7 minutes. Now that's an extreme situation, but we have lots of kids that have some physical conditions. They've been so deconditioned. And again, you have to be careful with the goals you set, because the last thing you want to do is to set a goal too high for them to struggle and then them say, see, I tried, I can't do anything. And you're gonna take a step back. So you really have to kind of think about these targeted goals. These are the gold standard, and we have to work our way back. The other thing is, I think when you start talking about setting goals in pediatrics, we talked about some of the psychosocial issues. We talked about screening for depression and anxiety. I think one of the things we have to be just brutally honest about is not just that, but behavioral issues. We see lots of kids that come through our clinics that the parents have difficulty getting their kids to bed, getting them to go to school. And I got news for you. If mom and dad can't set limits for things like that, how successful do you think they're going to be at setting some new limits about dietary? Because we have some families where, there's significant behavioral issues and we really need to get them hooked up, and they need to see psychologists, do PCIT, parent-child interaction, because parents can't set any limits with them. The kids are running the household. Is it just in Oklahoma? I'm sure that you got a few of those kids in Kentucky, right? Or have you guys been shipping them all to us? Is that what the deal is? We get all the non-compliant kids? Is that what's happened? So I think that's one of the things, and the reason I bring this up is because every time I see remove TV from a child's room, you have to prep your families for that. Okay? All I can say is that is an aspirational goal. I think it's a great thing. My kids don't have TVs or anything like that, but if a kid has had a TV in their room for some time, and they come in and see you and you just kind of offhand make the remark about, hey, the best thing to do is take that TV out, you might be setting that family up for some destructive behavior right there. Okay, so one of the things to keep in mind are these are goals, but you have to think, okay, what can the family take on right now? What are the resources? The last thing you want to do is to set them up for failure. Okay?
One thing that I discovered when I was working in the schools is I talk about bedtime, and what's for a good person, as a middle class person, it was like you go to bed. Well, a good percentage of these kids go to sleep where they lay.
Yep.
They don't go to bed. They fall asleep on the floor, on the couch, anywhere. So this is just.
Yeah, and I'll use an example. So in our multidisciplinary clinic, we typically have, for our return visits, we don't see them in any particular order. So maybe Dr. Whedon sees them first, maybe I see them first. But for our new visits, Dr. Whedon sees them first because she goes over all the medical, goes over their labs and things like that. Then they'll see dietitian or physical therapy. But psychology always sees them last. And we see them last because they tend to be kind of overwhelmed at that point, and we kind of see our job is to kind of make sure they're all kind of put back together, they understand their goals, and they're going to be able to do that. One of the issues that sometimes happens is when the families hear about their lab values, mom and dad are willing to do whatever. And so, they have this, we're willing to set a couple goals, and they decide they want to turn the world upside down. Now, a lot of times we realize that that'll only last for a couple days, right? Because they're kind of scared. They're probably not going to be able to maintain that. And so that's where the remove the TV, I'm like. So I think one of the things you always have to think about is we have these target goals. You have to think about what can we start to do. And then also, even if they're interested in, maybe sometimes we have to kind of tamper that down and say, we don't want you to bite off too much. That's a great goal. Let's work up to that. But I think sometimes you have to kind of bring them back a little bit. Other questions about some of the goals? So again, we started talking about incremental versus gold standard in the 5210. Also thinking about short versus long term. We're in it for the long term. Okay, if you're thinking about a multidisciplinary clinic, you think about it from a primary care standpoint, you're not just thinking about changing that behavior for the next week or the next month. We're all in it for the long term. Okay, so we can think about what do we want that behavior to look like 6 months from now, a year from now. We don't have to fix everything at once. So I encourage you to think when you think about developing goals, what's our short-term goal and what's our long-term goal? We want to build. Because we know if they come back in and they have some success, we can reinforce that. It's going to be reinforcing for them. We can build on it. I do think, though, that one of the things that we do a lot in our clinic, when we think about incremental versus gold, think about short versus long-term, one of the things we always talk about, I try to have a conversation with them about, is I say one of the most difficult things we have in our clinic is knowing, and this gets back to that MI principle of being collaborative, how much to push. And I will be real honest, and I'll say, Mom, I know if you feel like we're pushing too much, you're going to push back. But we struggle with that because we have some families that will say, I think we're moving too slow. And so we have a conversation about, we're going to have to be honest with each other. If you want more, we can give you more. But the last thing we want to do is to push too much because we don't want it to backfire on us. So I encourage everyone to have an open discussion about that. Again, we want to collaborate. So that means on goals, short-term, long-term, to have that open dialogue about, I want to match you. I want to match you and your family for what you're ready for. But I don't want to hold you back. If you want to do more, I want to find a way to facilitate that, which I think is very, very important. So let's get at something that is huge about this, is that for all of our interventions, it's family-based. Right? The worst thing we can do is for a family to come in and you've got parents there and there's 3 kids in the room, Johnny's the identified kid, and they start talking about, we're going to have Johnny eat this, or we're going to have Johnny do this. But Susie, she's skinny, so she doesn't need it. Does that ever happen? Or are you just shipping those families to us as well? Are we the dumping ground for, okay? Because we see that a lot, where they'll go, they don't need to make that change because she's skinny. Now, we're in a group of here of medical folks, and you guys realize that just because they're skinny, if they're eating those foods, their labs are still probably messed up as well, right? Their cholesterol's messed up and things like that. So one of the things that we're big on is, and this is whether it be primary care based or specialty care based, is when we start talking about changes, it's family changes. So it's not about getting, if you think about our goals, we think about, the physical activity goals, the dietary goals, those target goals, none of that is outlandish, right? That is all good, healthy lifestyle. And so it is good for everybody in the family. So we always tell people, we're never going to ask you to do drastic things. We're never going to implement strict diets. We're not going to do that. It's about healthy lifestyle choices. So it's going to be things that the whole family can and should do. And that's got to be said at the very beginning, and not just said at the very beginning, it's got to be said every time. Because people will do what a couple of you guys are doing and nod your head, right? And families will nod their head like, I get it, and then they'll come in the next time and they'll go, oh no, we just made Johnny do that. So I got to give you an example. And a lot of times, and I think part of it is, we talk about this and we think, man, this sounds so simple. And then we get these stories back from families and realize they had no clue of what we were talking about, or they had no idea what the fundamental issue was with the goal. So the example, and Dr. Whedon alluded to this, she was going to steal one of my best stories. It's all right. It's all right. I'm not going to give you a ride back after this.
No, it's my favorite story.
So this happened when I was doing more primary care work, and I'd been called in to see this family, and she was a 12-year-old female and was obese, and the pediatrician came and got me, and so I started to see them for a few kind of short-term therapy just to kind of work on making some changes for to decrease her weight velocity. And the very first time we met this family, we were just kind of going through, again, kind of big picture things. Do you eat in front of the TV? Do you skip any meals? And one of the things they did was they all ate in front of the TV. And so, and they would eat and they would eat. And so we said, one of the things, talked about different options. And they said, well, one of the things we're willing to try is to not eat in front of the TV anymore. And I said, really? I mean, we laid out all these different things. And they said, no, we can do that. I was like, are you sure? Yeah, we can do that. So they come back in about 2 weeks, and first thing we do, after we had a little chit-chat about checking in, I said, well, your goal, one of the things you said you're going to do last week was not eat in front of the TV anymore. How was that? They go, oh, we did it. I said, really? I said, because they even talked about they didn't have a dining room table, and so they sat on the couch or whatever. And I said, how'd you do that? I swear, this is a true story. The dad said, we just made her turn around. And I said, what are you talking about? She said, well, my wife and I, we still sit on the couch, but she sits in a chair now. She just turns around. So mom and dad were still eating their meals, watching TV, and this little girl is sitting by herself over on the side, turned around. We all laugh. I think that kind of stuff happens a lot, where we have a clear idea in our head about these goals and about the importance and about the underlying, why it's important and what it gets at, and people will try to implement them, and sometimes they really don't. And so to me, that was this awakening of, a lot of times people will do things and they'll try to implement things, but they really don't get it. And I think that is a true story. I remember it like it was yesterday. And he was just, we just make her turn around. I was like, what? So, and
What'd you do next?
what's that?
What'd you do next?
I said, well, we need to backtrack. We need to talk about the intent of what that was for. So it wasn't just for her, and they really, I mean, it was naive. I mean, they weren't trying to be manipulative. They just didn't realize. They just kind of thought, oh, you don't want her watching TV. It was like, no, you're missing the point. I think stuff like that happens more often than we think. So you got to have parent involvement, right? So again, it's family interventions. One of the things we talk about with siblings through our Healthy Futures Clinic is I tell parents, you can think about this as intervention for the identified patient, or you can think about it as prevention for everybody else in the family. But we want everybody doing the same thing. You can call it whatever you want, intervention or prevention. Because they'll say, well, I got 2 twins and they're pretty young. And I said, well, it's going to be prevention for them. But everybody needs to do these things. So if the parents agree, the goal is to reduce sugary beverages, or they said, yeah, we're only going to drink pop when we go out to eat, so we're no longer going to bring it in the home. That's got to be for everybody. Because we run into issues, and you guys will too, where they'll say, okay, we won't keep that, but mom and dad have their own refrigerator in the back room, or grandma's got her own stash. or I keep it out in the car. You can't have that. Now, sometimes you can have that conversation and they're going to push back and they're going to say, I don't know if I can do that. And that's where that long-term vision has to come into play. Because if you push them too much, they're going to close down. But what you can do is later on, if they're not making progress, you can always kind of go back to that and say, you know, and again, this helps doing the lab values. If they're not willing to follow through on some of those things and you see them later on and they haven't made the progress, then you can say, well, you know, I think, you know, as much as you're working in this area, I think we're going to continue to struggle until you decide that you might be able to make that change. Again, this is also where some MI can come through. So if you have this happens quite a bit where, unfortunately, we only have one parent that comes in clinic. And when we're talking about sugary beverages and say, you know, we're going to reduce these and they're on board. And then after a while, you realize, well, why, you know, why is he still drinking, you know, Dr. Pepper? Well, Dad really loves his Dr. Pepper. And it's like, okay. So the only time it comes in the house is when Dad's around. Okay. So then we'll say, so, you know, what would it take to get that out? Well, I don't know. You know, Dad really loves his Dr. Pepper. And so that time, you can use some of those MI things. And one thing that I think is very strategic that I do sometimes is I reflect back. And I reflect back with a horribly inaccurate reflection. But I'll reflect back and say something like, yeah, that'd just be too tough. No matter what happens with Johnny's, you know, health, it'd just be too tough for Dad to give us Dr. Pepper. And when that comes across, they go, oh, wait, no, I didn't say that. And they'll start to backtrack. So we call that an amplified reflection, where you take it to its most extreme, where you say something like, you know, no matter what happens, no matter what happened with his weight, there's no way, it's just impossible. You can never quit bringing Dr. Pepper in the house. And when you kind of hear it like that, they go, I don't like the way that sounds. Because that kind of makes me sound like a bad parent. So sometimes you can amplify that and take it to its extreme. Now, you have to be strategic. Now, if it's the first time for you to meet that family, you probably can't do that. But as that develops, you can do some of those things. But again, you have to realize that you got to have that family involvement. One of the things we always talk about is choice. So we think about when you set goals, we talk about the parents provide and the children decide. Okay? The parents provide, you know, the parents are the ones that buy the food, they prepare the food, they allow access to the food. Okay? But we need to try to build in as much choice as possible by the kids. Same thing, if you talk about physical activity goals, a lot of times kids are going to want to do all kinds of things, but usually they're dependent on their parents to buy a bike, take them to the park, take them to the Y, do all those things. So it's a combination. So we always talk about the parents provide, the children decide. So when you're negotiating goals, you have to talk about what are the resources, what are the parental options, and then try to give the kids some choice. Okay? And that's one of those things, because again, when you're in your clinical encounter, you're managing the parents and you're managing the kid. And sometimes it's easy for us to get so focused on the parents, but if we don't find some ways to build in some choice to get those kids involved, our interventions aren't going to be very effective. So you got to find some ways to give some choices. Let them decide. Okay? It's kind of like the old, you know, as a pediatrician or a family practice doc, and, you know, a young family comes in and goes, it takes me forever to, you know, get my kids dressed in the morning, you know, because it's this big power struggle. And typically what you guys will say is, look, you need to pick out 3 outfits and let them choose. You can't just say, well, let's you know, arm wrestle about everything in the closet, right? Parents decide what the choices are, and the kids choose from that. Same concept. You have to find a balance for that. But you can't, if you just go one way and you talk with the kids are going to want to do things that a lot of times your parents can't support. I want to go to the YMCA. Every day. Well, the parents work every afternoon, and that's not possible, right? Or a lot of times, kids want to do things that cost lots of money. Most of our parents don't have lots of money to support that. So you have to figure out what are your parameters. The other thing is, again, kind of get back to the SMART goals. Specific, measurable, attainable, realistic, and timely. Okay, and we really hammer this out. So in our clinic, and you're going to see it in a minute, we have a goal sheet we use at the end of each of our sessions. And we don't fill out goals for our parents and our families. We flip it around and we'll get the kids to write. We tell the kids, look, I don't care how you spell it. It doesn't matter to me as long as it makes sense to you. Kids have to write things out. And the first thing you say, okay, what do you want to do? I'm going to exercise, or I'm going to play more. It's like, okay, we're going to have to work on that, because what you think play more means and what I think, I don't know what that is. We have to break that out. How many times a day, how long, you're going to have to really kind of break those things out, because you can't measure it. You can't measure success if you're not specific, measurable, and it's got to be realistic. So we're huge on SMART goals. Okay, now I think that's one of those things where we're collaborative. They come up with the idea and then we help refine it. Okay, that's where that collaborative piece comes in. So an example, instead of eat less fast food, you got to, okay, so is that going to be limit fast food to once a week, twice a week? What's that going to look like? Again, so an example, eat more fruits and vegetables. What the heck's that mean? So again, for all these, it has to be specific, measurable, achievable, realistic, and timely. The other thing, and again, when we think about realistic, you got to start thinking about barriers. Because a lot of times, and this probably happens with a lot of you, but in our clinic, unfortunately, a lot of times we'll have one parent in the room, okay? And we'll start developing goals that involve both parents, or involve grandma and grandpa, or things like that. So you have to start thinking about, okay, how realistic is this going to be? And start to kind of do some of that problem solving. So again, we think about goodness of fit. So after we set some goals, again, how good of a fit is it? Is it going to be realistic? Is it going to be attainable? Again, one of the things is you want to make sure that they don't bite off more than they can chew, right? It's got to be something that they can fit into. And so we'll say, okay, sounds like a great goal. Or here's another way to kind of test it. So if you're seeing them in the early afternoon and they say, okay, our goal is going to be every day we're going to do such and such. You can kind of test them and say, okay, so you're going to be able to do this when you go home today? Are you going to be able to do this tomorrow? Well, no, but tomorrow we've got church and we've got this. So you got church on that day, so you won't be able to do it that. Are there other things that are going to get in the way? And then all of a sudden they start thinking, they're like, crap, we could probably only realistically do that about twice a week. So you really have to look for that goodness of fit and kind of walk your way back to see how practical it is. So we think about barriers, you got to do that active problem solving to start thinking about what's going to happen when they implement it. And then you have to think about monitoring. And I'll tell you, one of the worst things you can do as a clinician is spend all this time and effort into setting goals and being very specific about those goals, getting them to think through and problem solve and be specific and measurable. And the next time they come in, you don't even talk about them, right? Because it's kind of like teachers that give out lots of homework. And then if you quit recording the homework, you quit asking for it, imagine that, people quit doing it. So the same thing, if you're going to spend all that time to kind of set those goals, you've got to go over it. You got to allow some time in your day to kind of go over that in your clinical encounter to make sure they realize how important it is. So you got to problem solve, you got to monitor, and we contract. So again, on our goal sheet, we have them write out the goals, and then we have them sign for it. And I do lots of cheesy things when I'll ask the kids. I'll say, now whose goals are these? Because I want to check to see if they say, oh, they're mom's goals, right? I want them to say, oh, they're my goals. And if they kind of pause, I'll say, they're your goals. They're not my goals. That's why we have you write them down. That's why I want them in your words, because they're your goals. So here's an example of a goal kind of contracting sheet. So again, we use this for our clinic. So again, just like some of the same things we've talked about. So we've kind of branded with the 5210 again, because that's kind of our gold standard, right? We want to have that messaging. And then we try to have no more than 3 goals. Okay, so we usually, in every session, we're going to have some kind of dietary goal and some kind of physical activity goal. And in our session, or in our clinic, a lot of times they come in to see dietitian and psychology. And so psychology, we get to be the physical activity people. So the dietitian will set the dietary, and then the behavioral health person is the one that helps do the physical activity. But again, so we always set goals no matter what. So my question to you is, what if a family's been going along and at the end of session, you want to set some goals and they go, I'm just really not sure. Or if they say, we just want to maintain what we've been working on. Is that okay? Is it okay to say, okay, we'll just, so your goal is going to be to maintain. Is it okay for them to do that? Crickets. Crickets. You say no? Maybe?
That's what they want to do,
Yeah, yeah.
their goal.
Yeah. So what I would say is if that's what they want to do, then I would say yes, but then I would have them write down what that's going to look like, right? So part of it is because, again, what you don't want is them say, yeah, I don't need to, we're just going to keep going. Because then you come back and say, so what's keep going mean? Tell me, break out all the dietary things that you're still working on. Because I want to make sure they realize they're still working, they're still doing those things. As long as they're still working and they're doing those things and we can kind of track it, I think that's fine. Now, I think what you can do is you file that back later on and say, because you don't want to push too much, but then if they keep doing that, then you can have that discussion about, so, what kind of progress do you think you're making in clinic? Do you think, or again, 6 months come up and we repeat labs, and if they're not happy with their labs, you can come back to say, for the last couple of visits, you guys have just been kind of wanting to maintain. What do you think about that? On the one hand, you want to maintain, we'll do MI. On the one hand, you want to maintain doing the same goals. On the other hand, you're not happy with your labs. What do you think about that? Because I'm a big one in use that data and let them kind of sit on that. But I think for the most part, if you try to push them too much to come up with goals, sometimes you'll get pushed back. So if they just want to say, we're going to keep on doing the same thing, have them break that out. Let's be specific about it. I just want to keep doing the same thing, same dietary, but what are those things going to be? Physical activity, what that's going to be, and break it out. Here's the other one that a lot of people use, again, where you can kind of pencil things in a little bit, again, just to show you some examples. So the other thing we talked about is follow-up and reinforcement. So how do we assess, and what do we reinforce? Okay, and this is big picture. We talked about that for most of us, we realize that weight loss is not our target, correct? We're about health, okay? We realize though that sometimes that our measurement of health isn't going to be until repeat labs and things like that. So for the most part, for our behavioral goals, we're measuring success with those behaviors. So if their goal is to get out and walk 3 days a week, we measure their success on were they able to follow through with that behavior. And that's where it's tricky because you have to really kind of reinforce that for the parents, that right now we're assessing your success with those behavioral interventions. So you have to have that conversation about that success, not because what will happen is you'll see someone for the first time, they get weighed and measured, you find out their BMI, all that kind of stuff. We see them, they come back in a couple months, and they will have said, we've been walking every day, we've made these changes in our diet, and their weight's the same. And they're going to think, I failed. So you're going to have that conversation about, we're measuring success right now by those behavioral changes. The other stuff will come later. We're not going to focus on the weight so much. We're going to focus on these. And that's a constant, consistent message that you have to have. And when you got to reinforce, okay? Even when they don't meet their goals, what do you have to reinforce? You have to reinforce their effort. You have to reinforce them being honest with you. That's where you kind of problem solve. But you have to reinforce them for making efforts at those changes. Okay? So if they come in and they say, yeah, we're supposed to do that 3 days a week, we only did it 1 day a week. Praise them for doing it that 1 day. Because that's 1 day more than they were doing before. That's a step in the right direction. Again, that's not our gold standard. But remember, our job is in our mind, we have a pace we want everyone to be on. We're going to have to kind of step back and we got to meet them where they're at. Okay? So you got to figure out how we're going to assess that, and you got to reinforce it. Barriers. You really have to, and I talked about this a little bit before about barriers and problem solving. When you come up with the goal, you have to kind of walk them through what that's going to look like every day. Who's going to do it? You're going to do it? Is that going to happen with mom? Is that going to happen with grandma? What's going to happen when dad's there? You really have to walk them through it. All right. So one of the things that I hope you get out of this is I've heard of a dinner bell, and I thought she was ringing it. So hopefully one of the things you saw is that, again, MI is how you start the conversation. but you've got to follow that up with goal setting. Because we see that happen a lot where you'll get parents and kids ready for it and they set unrealistic goals. And then when they come back in, they're frustrated, we're frustrated, so you have to marry the two. But I will tell you that you need to spend just as much time you spend on the MI, you really have to do that with the goal setting. And you really kind of walk people through. You know, if at the end of the session it's kind of like, oh crap, we didn't come up with goals, and you quickly do something like that, it's kind of one of those things, you know, you'll probably get out of it what you put into it. So if you don't put much time and thought in it, chances are you're not going to get much out of it. So I really encourage you to spend some time with that. It's really, really important. The other thing is, again, how you reinforce it. You're reinforcing effort. If you think about, for a lot of the patients and families that come into our clinics, they have been doing literally nothing, right? They've been eating horribly. They haven't had much physical activity. So any kind of approximation, any kind of change, any behavior change, you got to really reinforce. Because again, we're in it for the long haul. We're not in it for a short change. We're in it for a long-term change that's going to benefit their health for the rest of their life. Questions about that? Yes, ma'am.
I think I could see where some parents might think you're reinforcing weight loss, because the first thing you do is put them on a scale when they come in. I mean, you see what I'm saying?
Yep. And it's interesting. So we were at, Dr. Weed and I, we were at a national conference a couple of years ago, and it was at PAS, which, yeah, the obesity SIG, and there was a big discussion, and this was people from all the different weight management clinics, and there was discussion about, do you do height and weights at every visit? Do you not do them at all? Because again, the idea is we all agree not to focus so much on weight, but at the same time, you know, we still measure BMI and things like that. So there's a pretty healthy, you know, discussion about that, and it's mixed. My thing though is families have scales at home, and those kids are stepping on those scales, and those parents are seeing the scales, they're having those questions. Even if they're not coming to our clinic, if they go in for their primary care or another thing, the first thing you get vitals, they're getting weighed. So to me, it's one of those things where it'd be great if we lived in a world where that never came up, but we don't. And if it does, I want to know how they perceive that. So that's why I go out of my way to talk about it. Not to focus on it, but to try to put it back in a healthy context. So I go out of my way. But that's kind of, but we have gotten some pushback where parents are like, I don't really get this. Or we've actually gotten pushback, or not pushback, but confusion about why is the psychologist talking about that? Because to me, it's less about the number, it's more about the perception and the attributions you make. And that's kind of my ballgame as far as psychology goes. So to me, it's less about the number and more about if mom's worried about weight, if mom's looking at the scale, if we need to know that, because that's something we have to work on. And we've had this discussion before, but we think probably even in our clinic, it probably takes about 6 months before they really kind of get the idea that it's not about weight, it's really about health.
And that's when it starts happening.
Yeah,
There's
yeah.
the BMI starts moving.
Because for a lot of them, again, intellectually they get that. I get it, it's about health. But they still get focused on it. And we as providers do. I mean, because we have a system in our clinic where after they room the patient, they come in, they write the vitals down and things like that. And we even, you know, it's like, oh, they've gained or their BMI is the same. And so we look at it. But I think it's more about making sure we all kind of put it in context. Great question or comment. Other questions or comments or other thoughts about that?
And I would just say, to follow up on that, I mean, we also point out, I mean, it's a lot of times when we're seeing the kids, they've been building for years to get there, right? And so to have that down, you know, to be looking at for an immediate weight change, even just maintenance right off the bat, I think it's hard when they've been climbing, you know, for so long, and they've been in that category for so long. So we really, like, when we look at our data, we start seeing it really around the time that the family's finally like, oh, maybe, you know, they're starting to focus more on kind of the health, like it takes that 6 months transition. That's when we really start seeing that, because they're getting more consistent and they're adding goals, you know, like one change on top of another. So, you know, by 6 months, they have several goals. So they're actually doing more and more things to affect kind of BMI change. And so it's around that point that we actually really do start seeing it. And on that point, they're kind of totally, they're either on board or they're not there.
But one of the things is, a lot of times, even so, if they come back in, say it's been a month or 3 months or whatever, and they come in and their weight's dropped and their BMI's dropped. I mean, I'll give them feedback on that. But one of the things I talk with them about is, talk about the goals, reinforce them about their goals, and that's great, working really hard. You've had this decrease in BMI, so that's another, kind of indication that you've been working hard. But we'll even kind of do a little bit of kind of forecasting and say, even if you keep doing those things, just let you know, you're not always going to come in and your BMI is going to always drop. Your weight's not always going to drop. That's just not the way we are. So when you feel like you're working really hard and your number stays the same, that's okay, because that's going to happen. Because if they set the expectation that every time they come in, it's going to be like that, that doesn't happen. And for various reasons, because we've got kids from 4 to 18, and kids going through adolescence, and their kids are in football and they're lifting weights. And so there's could be 100 reasons. And so to even have that discussion about it's not going to be a nice linear every time you come in, it's dropping like that. And from looking at the guidelines, for a certain percentage of our kids, again, the goal is kind of weight maintenance, right, or slow down the velocity.
How long do you keep your patients?
Forever. Yeah. Now, so what will happen is, so we don't, it's an open-ended. So we have kids that will age out of our program, like at 18. Now, what will happen with a lot of our kids is the only time they'll come in is every 6 months for their comprehensive visit. I think that's great, because then they get labs. It's a way to kind of monitor, are their labs still in check? Because that's what we're at, kind of the health and prevent those kind of comorbidities. So even if they're doing everything great and they've made tons of progress, we still recommend, at least kind of come in every 6 months. We don't want to lose you.
And the families ask for that, is what we've seen. So our families so we've been open for 3.5 years, and we have families, in there for over 3 years, and they want some accountability. They just want to check in and see where they are. There's different growth, developmental, right, through this too. So our kids that start, school age, or that are going through puberty, it's checking in on how all those factors play into their overall health and weight and BMI.
It also kind of gets back, I think, long term, we think about behavior change. A lot of times we do certain things to initiate change. We have to do other things to maintain it over time, as the system changes, as they get older. And so you got to keep kind of tweaking it. And so at least having the 6 months allows us to have those conversations. Yes, ma'am.
This just made me think of this now, but do you have a success rate for families that you just can't get anywhere with?
So I will tell you, because I think it's interesting, from my standpoint, we have much more success with younger school-age kids.
Starting younger?
Yeah.
Preschool,
yeah.
and school age.
Yeah.
Most with preschool, then school, hardest with adolescents.
Hardest with adolescents. And I think that's, I think there's lots of good evidence there's lots of reasons why. Because when they're younger, then again, the parents are really setting a lot of the stage for that. The other thing is, in our state, because I know that we talked a little bit about reimbursement and funding and things like that. In our state, for our Medicaid, our participants, our patients that have Medicaid, we get pretty decent reimbursement. They reimburse all 4 providers. And so for our private insurance companies, we have issues where they won't reimburse for obesity, and sometimes they won't reimburse for the dietitian or physical therapy or things like that. And so the worst case scenario is about a 16 or a 17-year-old adolescent that has Blue Cross Blue Shield or has private insurance. Because the other thing is that if you have Medicaid, you can see all 4 providers. If you have private insurance, even if you see all 4 providers, you get stuck with a copay. So if you come in a multidisciplinary clinic, you got 4 copays. And everyone can be, yes, I love the clinic, I'm going to come in. And if they keep getting hit with copays for 4 providers, after a while it's like, yeah, I want to see you every 6 months. And so it really impacts how much work we can do. So to me, that's the most difficult, an adolescent with private insurance.
Steve, wouldn't you say also, unfortunately, it's the most severely obese that have the lowest
Yep.
Yes.
Yep.
success rate
Yep.
too?
Definitely. definitely. Yeah, no, I think it is an area that needs much more attention. Yeah, definitely.
But, and it just even comparison, so we have some morbidly, we've had at least one morbidly obese, 2, almost 3, I mean, like 75-pound 2-year-old, right? So, and then we already talked about that teenager. We've seen a huge downtrend on the BMI on that two-year-old going to 3 to 4. You know, I mean, they came in, parenting strategies were off the chart. There was no sleep, there was behavior, all the foods. They lived in rural Oklahoma. They travel an hour and a half to get, you know, so they're convenience stores or grocery stores. So every single environmental factor, all of it together, parenting. And so, but she was so concerned. I mean, you know, beginning to have blouns, looking at surgery, dyslipidemia, sleep apnea, like all of this stuff. And so this family got on board and has been on board. And it's been amazing to see the change in like severe obesity for like a preschool age kid versus the severe obesity in our adolescents, which it's so, I mean, it's really hard. And that's my biggest struggle is trying to change it. So many of those behaviors are set. And then when they're at that severe obesity, I mean, even the physiology, I mean, it's difficult.
Yeah, I think the other thing is with adolescents, you know, it's easy when you have a young kid to talk with the family and talk with a kid about, you know, kind of growing into your weight and how things are kind of level off. And when, you know, you're talking with a 16-year-old, they're like, yeah, I don't think I'm getting much taller. But you know, our clinic is very much on less emphasis on weight and things like that. And you have that period where even when you saw in the guidelines that for adolescents, certain things, weight loss does start to become the focus. And the adolescents are much more about, I want to fit into this by next summer and things like that. And so I really think in an ideal, you kind of have two populations and kind of two different clinical approaches. I think right now we kind of try to, because we're the only clinic, we try to do all that. Because I do think there are some very significant things that are different with adolescents. All right, thank you so much.